about the next speaker, I am honored and delighted tonight to introduce our professor, Dr. Adel Hussein, is a well-known figure in the field of critical care medicine. And Dr. Adel is graduated from Cairo University Hospital. He has MD, PhD critical care in 2002, and he is former assistant professor of critical care medicine, Cairo University. Dr. Adel is currently a consultant critical care medicine in King Abdullah Medical City, Makkah al-Mukarramah, Saudi Arabia. Dr. Adel is going to talk tonight about one of the very important topics in the acute kidney injury topic. And there is a lot of debates here in this topic. It is about IV diuretics. Shall we use diuretics to convert the oliguric renal failure into non-oliguric? And should we use it as IV boluses or infusions? And a lot of debates in this area. Dr. Adel is going to answer these questions and more. I would like to welcome Dr. Adel on board. Dr. Adel, the mic is yours.
Thank you, Dr. Sarwat. Assalamu alaikum wa rahmatullahi wa barakatuh. So, Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Wa salatu wa salamu ala ashraf khalqillahi wal mursaleen. Sayyidina Muhammad. وعلى آله وصحبه وسلم تسليما كثيرا. أسأل الله تبارك وتعالى في هذه الليلة أن يجعل ما نقدمه نافعا لنا ولكم جميعا. First of all, I have to thank my beloved brother, Dr. Sarwat, for his nice presentation. And also I have to thank Dr. Saad and the Mega Academy for giving us this opportunity tonight to be among our elegant speakers, Dr. Madi, Dr. Shams, and Dr. Zainab, to have some contribution about the IV diuresis and acute kidney injury. The topic is now merged after Dr. Madi elegant presentation, Dr. Shams very nice elaboration about the hepatorenal syndrome. So my colleague Dr. Zainab, she will talk about the renal replacement therapy. But my role tonight about talking about the IV diuresis in AKI, when, as timing, how, as dose, or as mode, and what common methods that usually we found it or we face it during the clinical practice at bedside. For conflict of interest disclosure, I have nothing tonight to disclose in my lecture. The objectives of my presentation tonight, I will highlight the brief overview of diuretics in AKI. The second will be the therapeutic role of diuretics in AKI, including the volume management, if there is a role for prevention of AKI by using diuretics, or volume expansion. What about the therapeutic role of diuretics when we have established AKI? Then we will move to the role of diuretics for AKI prognostication. I will highlight about the diuretic resistance. Then I will highlight the common methods about our friend in the ICU, which is the IV Frisomite. Then I will sum up with some tips for the effective diuretic dosing and management in the setting of AKI in critically ill patients. Let's start with the first part of our objectives tonight, which is the overview about diuretics and AKI. So if you know about the AKI, either the native or the de novo AKI, or AKI on top of CKD, we have risk factors, we have causes, and we have outcome, and of course the lines of management. So when you manage your patients with AKI, either, as I mentioned, native AKI or AKI on top of CKD, I have risk stratification or risk factors. I have the common causes that this is the risk factors, of course, is related to our patient who presented with AKI or he developed AKI. We have the common causes or the common underlying etiology, like sepsis, cardiac surgery, contrast-induced neuropathy, toxicology, drugs. So there is a heterogeneous causes for AKI. Lines of management, either diuresis, volume expansion, RRT, or renal replacement therapy. Then the expectation for the renal recovery or the recovery from AKI, or he will continue as dialysis dependent. And what about the mortality? So for the role of diuretics, which is my topic tonight, just back to pharmacology, just to as a reminder about the classifications of diuretics. We have carbonic anhydrase inhibitors. We have loop diuretics. We have thiazide diuretics. We have potassium sparing diuretics. And we have osmotic diuresis. Those are the 5 classes of diuretics that we are using. Sometimes we use the osmotic diuresis. Potassium sparing diuretics, we usually use it in heart failure patients. Carbonic anhydrase inhibitors, usually we are not using a lot unless in some specific scenarios, not common in ICU, except if you are treating some metabolic alkalosis, for example, or people who are presenting with glaucoma. But we are playing commonly with lobe diuretic thiazides and the osmotic diuresis for high ICP or for hyperosmolar therapy, for example. So those are the common classes, but being an intensivist, you should know basically what's the mechanism of those diuretics. Most of the diuretics act how? They are acted by interfering with the sodium reabsorption by the renal tubules, and the end result will be a sodium and water excretion. This is the mechanism where the sites of action is totally different, and I will show you where each one of these diuretics, where it acts as a site of infection, as a site of action. But we should know also those diuretics affect the carrier or the transporter, because there is a transporter at the luminal membrane of the renal tubules, if you remember the physiology. So those are the common sites for the diuretics regarding the sites of action and the common types. As I told you, we have mannitol as an example for the osmotic diuresis. We have acetazolamide for the carbonic anhydrase inhibitors. We have the lobe diuretics, and we have thiazides and the potassium sparing. Those the common 5. For the nephron here, we have the proximal convoluted tubules. We have the proximal straight part of the proximal convoluted tubule. Then we have the sec ascending lobe of Renal. Then we have the distal convoluted tubules. Then we have the collecting tubules. So just to remind you that for example, here is at the proximal convoluted tubule, this is the site of action of the carbonic anhydrase inhibitors or the acetazolamide, while at the ascending or the thick part of the ascending lobe of Renal, we have the LD or the lobe diuretics, pimetanide, frisomite, torsemide, ethacranic acid. This is the site or the common site of the loop diuretics, while the thiazide diuretics is at the DCT or at the distal convolute tubules. The potassium sparing diuretics, spironolactone, and the other friends for spironolactone, amiloride, and trimetrin at the collecting tubules. So just to know where we are, because here is how effective will be your diuretic, why your diuretic is weak. When I talk about acetazolamide is the weakest diuretic in its property. When you have one of the most common diuretics are combined, for example, for antihypertensive is the thiazides, which is acting at the distal convolute tubules. But our friend tonight with the loop diuretics that commonly we use in the ICU, this is acting at, or the site of action, or the preferred site of action in the nephron here as the, don't forget, it's the ascending lobe of Renal. The loop diuretics, and under the class of loop diuretics, we call it high ceiling diuretics. Why we call it high ceiling diuretics? Because they are the most potent diuretics. They have a natriuresis between 25 to 30% of sodium is reabsorbed. And in the ascending lobe of Renal, here is responsible for the active reabsorption of the sodium, potassium, and chloride transporter. This is the co-transporter to have the diuretic effect at the lobe of Renal, or the thick part of the ascending lobe of Renal. This is part of the physiology. Here is the comparison of those high ceiling diuretics like Frisomite, bumetanide, torsemide, and ethacrenic regarding the potency and the half-life. For example, here is the Frisomite. We have a half-life of 1.5 hours. For bumetanide is like 0.8 hours compared to torsemide is 3.5 hours. Now, just I give you an overview or brief overview about the diuretic site of action classes. Let's to move about the therapeutic role of the diuretics in AKI. Regarding the volume expansion in AKI, every day, as Dr. Ahmed said, regarding the fluid resuscitation in sepsis, in hypovolemia, we are giving volume. We are doing volume resuscitation. Either you have dynamic indices or you do not follow the dynamic indices. But at the end, you are entitled to do or to practice the volume expansion to improve the AKI or to reduce the incidence of AKI. But really, is it the volume expansion is toxic? And this was an area of research since long time. And we have this study by Picard et al. In 2009, which is the Picard study, or the program to improve care in acute renal disease. We call it, they call it Picard study. It was a multi-center cohort study, included 610 patients with AKI in the ICU, and addressing the volume overload. And it was defined as more than 10% of total fluid excess in relation to the admission body. So the way the patient on admission, and they define grossly the volume overload as more than 10% of the total fluid in relation to the body, the admission body weight. What did they found in the study? They found that the fluid overload, when they diagnosed patient with AKI or when patient developed AKI, was strongly associated with 6D mortality in ICU. So this is really a significant association between the fluid overload when patients have AKI and mortality. And there was a significant difference if we can look for this Kaplan-Meier curve, there was a significant difference in survival among patients with or without volume overload at the dialysis initiation, or even in non-dialysis patients. So with a significant p-value. So this was really translated into a conclusion from this study, or the Picard study, that the cumulative fluid accumulation or cumulative fluid overload was associated with a significant increase in the ICU mortality. If really the fluid overload is toxic, the question is, are the diuresis or diuretics beneficial to treat or to overcome this toxicity? So this was the question regarding the role of diuretics, mortality, and non-recovery of renal function in AKI. This was a bit older study, like 18 years ago, in 2002. It was a multi-center cohort study, included 552 critical ill patients with AKI. About 59, and close to 60%, they received diuretics at the time of nephrology consultation. The use of diuretics in AKI, when they analyzed those group of patients, it was associated with increased risk of mortality and non-recovery of renal function. So it was two important outcomes, which is the increased mortality plus non-recovery of renal function. So the patient continue to have different grades or stages of AKI. So they concluded at the end, the widespread use of diuretics in critically ill patients with AKI should not be used routinely and should be discouraged, based on those two outcomes, which was one is the increased mortality plus the non-recovery of the renal function. This was in 2002. If we are talking about diuretics and its role in management of AKI, are the diuretics a friend or foe? So there is a proposal benefits and limitations, of course. So if you look for the diuretics from its physiology and pharmacology point of view, it has benefits, yes, and on the other hand, it has a limitation or drawbacks. For benefits, yes, we use diuretics a lot for overcoming or controlling the volume overload. When you resuscitate, then you start to resuscitate. So if the patient had the oliguria or have a stage of DKI, so you start using diuretics. Your aim is to control the volume overload. Second benefit is to convert the oliguric phase of AKI to non-oliguric AKI. Third is to reduce the renal energy expenditure. Fourth, it will improve, or it's proposed to improve the GFR or glomerular filtration rate. How? By inhibiting the TGF or the tubuloglomerular feedback. Plus, there is theoretical benefit that we call it renal, it flushes the kidneys. And this is just like a general term, which is used to flush the kidneys, which is a congested kidneys, if we have an AKI or we have a volume overload. So we call it a benefit of renal flushing. It's devoid of limitation? No. We have, of course, a risk for intravascular volume depletion. The non-oliguric AKI it may reflect the underlying severity of illness, and it may delay the renal replacement therapy because the patient is non-allogratic. I am giving diuretics, but on the other hand, the chemistry is not improving. The patient is still sick. I have still metabolic acidosis. I have a high lactate, so still producing urine, but this is not reflected in his severity of illness, and I'm delaying the renal replacement therapy because I'm using still diuretics. And the nephroprotective mechanism for AKI is really unproven from the literature and the evidence-based. So if there is a role of diuretics to prevent AKI, theoretically, the relevant in selection of high-risk AKI settings, typically patients with undergoing angiography, like coronary angio, like CT pulmonary angio, IV contrast for abdominal studies or CT pelvis, whatever the angio, or for example, subarachnoid hemorrhage, coiling. So for angiography and diagnostic studies, you are using the contrast. For elective nephrotoxic drug administration also, and cardiac surgery, of course. So you have high risk patients for AKI, patient with shock, patient with hypovolemia. So the classic studies for prevention of radiocontrast nephropathy, initially it showed there is no benefit of using IV diuretics alone in prevention of AKI. What the other intervention to reduce the incidence of AKI resulting from contrast or the so-called contrast nephropathy? There was recently an approach over the last 4 or 5 years now, they called renal guard therapy. What this approach entails? It entails the use of physician-prescribed loop diuretics, which may induce a required higher than usual urine output. It's designed to do what? It's designed to measure the urine output objectively, measurement of the urine output. Then you replace it in real time with an equal volume of isotonic saline. So this is the idea behind this renal guard therapy. So you collect the urine, you replace this urine with equal volume. If the urine output is 200, you replace with isotonic saline. If 100, you replace with 100, 150, 150. So we call it 1-to-1. So this method of fluid replacement, it aims to minimize the risk of over or under hydration, which can lead to the, of course, increased risk of AKI. This is the device or the renal guard machine or therapy. It enables the promise of high urine flow with therapy matched to reduce the risk of CIN or contrast or nephropathy. It incorporates many trials since it started. From 2014, 2015, like Metheus, Remedial, AG-Card, Bigori, AKI Guard, Protective TAVI, more than 100,000 procedures around us now. They are using this renal guard therapy, and it was incorporated to the European Society guidelines to endorse the renal guard therapy in high-risk patients. And this is what the statement from the European Society of Cardiology and the European Association of Cardiothoracic Surgery in 2014, and the recommendation for prevention of contrast induced nephropathy. They recommended using matched hydration with Frisomite over the standard hydration only in patients who are high risk for CIN, or in cases where prophylactic hydration before the procedure cannot be done. And this is I will talk just later about the technique, how they use it, and this is the strengths of recommendation. Many trials address the renal guard therapy, from latest here in 2020, just recently, and they are addressing the reduction of AKI post-cardiac surgery based on forced diuresis, and this is one of the recently published RCTs. Also in 2016, 2015. So many trials, as I'm showing you here, just not to go thoroughly through it. Here is just to choose one of the common trials, or the common studies that the address this issue. They call it Protect TAVI. It's a prophylactic effect of the Frisomite induced diuresis in matched isotonic IV hydration in TAVI. What TAVI? Which is the transcatheter aortic valve implantation. You know, it's a lengthy procedure. They use a lot of contrast. Those people usually they are high risk. They are elderly. They are heavy calcification. They have some cardiac diseases. Basically, they may have some CKD. So they are a high risk patients for developing CIN. The concept of forced diuresis was close matching of one-to-one volume to urine in patient with PCI. Renal guard device was central in this study, or the protected study. And this is the device. They are measuring the urine output in this collecting bag connected to the Foley's catheter. And this is the infusion of isotonic saline, of course, to the peripheral line. And here they are weighing and measuring the urine output objectively and compensating this urine to volume to urine one by one. This was the protocol of the study, the control group, compared to the renal guard, using the renal guard with TAVI, and they start the normal saline, 250 ml as bolus 30 minutes before the procedure. Then they start diuresis in the form of Frisomite at 0.25 milligram per kg at the time of procedure. Then they have a target. What's the target? The target of urine output more than 300 ml per hour. Once they have this target, which is the urine output of more than 300, they move the patient to the procedure, and they continue this renal guard, which is the urine to volume 1 by 1 cc replacement for 4 hours post procedure. And this was the incidence of AKI after the compared with the control. There was a significant reduction of AKI with the different stages, is there stage 1 to stage 3, comparing the renal guard group to the control group. Control group, they use only saline, all the procedure, 12 hours before, and 6 hours, they continued 6 hours after. So this was the rule of using the matched diuresis with hydration compared to the hydration alone. With this renal guard data, we have here many studies, like 3, 4, 5 studies comparing the efficacy of renal guard approach and reducing the incidence of CIN compared to the control group. And we can have it here clearly, the comparison of reducing the incidence of AKI between two approaches. Recently in last December, like 2 months ago, there was a famous study published called kidney study. It was using the renal guard therapy to prevent the AKI, and patients underwent cardiac surgery. The automated diuresis technology, this is the aim of this study. They included 220 patients. It was a randomized controlled trial. So it's an RCT. Those patients at risk for cardiac surgery with, of course, the cardiopulmonary bypass. The endpoints was the reduction of AKI within 48 hours post-surgery. The post-operative AKI rate were significantly lower in the renal guard group compared to the control. So 10 to 20%, they found a significant reduction of the post-operative AKI when they use the renal guard therapy. And they concluded that the number needed to treat with the renal guard system to prevent AKI was 9 patients. So this is something, the NNT was something significant. So from the kidney study, as I told you, it was just published a few months ago in patients post-cardiac surgery, there was a significant reduction and lowering the incidence of AKI using this matched urine to volume 1 by 1 to reduce the incidence of post-cardiac surgery AKI. There is a question is, do the diuretics have a role in treating exactly the established? Here we are talking about the prevention. What about the role of diuretics if you have established AKI? And this was the aim from the SPARK study. This was a randomized control study. It was a multi-center, double-blinded. They included 73 critically ill patients with AKI. It was early AKI. They have 2 or more of the SIRS criteria. They were resuscitated with the fluids, and they will have some exclusion criteria, which is the clinical need for Frisomite, kidney recovery, recent RRT, and the advanced CKD. The intervention, what they did to treat established AKI, they gave a Frisomite as a loop diuretic, and this was the dose. They give a bolus of 0.4 milligram per kg, then 0.05 milligram per kg per hour, and the control were just fluids with saline. They titrated the diuresis to target urine output of 1 to 2 ml per kg per hour. And the maximum dose of Frisomite given was, in the SPARK study, was 0.4 milligram per kg per hour. What's their primary outcome? Was the progression of AKI. Did the patient progress to the AKI or not? Here was not a prevention. Here is the progression of the AKI. So the outcome from this study, when they compare the Frisomite group to the placebo group, they have some variables, or commonly it's important variables like worsening of AKI, cumulative fluid balance, the kidney recovery, people who received renal replacement therapy, ICU mortality, hospital mortality. Not only this, mortality at 90 days related to those patients. So if you look here for the p-value, it's non-significant p-value if you compare the Frisomite to the placebo group. So the conclusion from the SPARK study was the Frisomite did not reduce the rate of worsening of AKI, did not improve the recovery of renal function or the renal recovery, or also it did not reduce the need for renal replacement therapy. This is very important. However, they found that there was more tendency to electrolyte abnormalities was with the Frisomite arm. So this was an important conclusion from the SPARK study when we look for the role of diuretics in established AKI. So remember, it did not reduce the rate of worsening, it did not improve the recovery, and it did not reduce the need for renal replacement therapy. If we mention the SPARK, just to highlight the SPARK score for post-operative AKI risk assessment. So as an intensivist, you may implement this score or this SPARK index. This was not related to the SPARK study, just I'm mentioning here for post-operative non-cardiac surgery. if you would like to stratify patients who will develop AKI or not. So this was a study published in 2019 to stratify or to get an index and classification, and it has some external validation. The aim was to estimate the risk of postoperative AKI in non-cardiac surgery and the related outcome, and the included preoperative risk factors with scoring for the age, the GFR, the gender, the surgical duration, the its emergency or not, diabetes, RAS, neuromuscular blockade or not, hyperbilirubinemia, anemia. According to those score, you have the classes, and based on the class, if you have more than 20% the AKI or critical AKI, if more than 10%. So this is the score between 40 to 59, and this was the scoring between A, B, C, and D is the one with the severest of the critical one. What's the effect of diuretics if we are using diuretics on daily basis for our patients? Now, what's the effect of those diuretics as part in the management on the volume overload or volume management strategy in terms of fluid balance, diuretic use, mortality in AKI? And I think Dr. Mahdi, he mentioned it in his presentation, which is the FACT trial. Not the FACT itself trial, it was in 2011. It was a subgroup analysis from FACT trial. And this was in a comparison of, if you remember, this famous trial for patients with ERDS regarding the restrictive versus liberal fluid management strategy in patient with ERDS. The primary objective with FACT AKI sub-study is to elucidate the association between fluid balance, diuretic use, and short-term mortality after AKI in those patients. They included, they analyzed 306 patients out of 1,000 in the parent trial who developed AKI. In fact, 1,000, those were the parent population. 306, they developed AKI within 2 days of randomization. The 60-day mortality was about 40% in both group, liberal and restrictive, closely. 40% in the liberal, 37.9 in the restrictive. Post-AKI fluid balance was significantly associated with mortality, both crowd and adjusted analysis. We have two types, the crowd mortality and the adjusted. Crowd, like the general, adjusted is related to the AKI, so post-AKI fluid balance was associated with mortality. Higher post-AKI Frisomite doses had a protective effect on mortality, but no significant effect after adjustment to the post-AKI balance. And this is very important, finding that higher doses does not have impact after adjustment for post-AKI fluid balance on mortality. There was no threshold doses for Frisomite above which the mortality increased. They did not mention it in the study. This is regarding the treatment of established AKI with diuretics. Let's move to AKI prognostication and how to use diuretics to prognosticate AKI. The prognostication is important. Why? Because you have to validate or to use a test or to use a score or to use an intervention to prognosticate the value of using the furosemide in AKI. So the AKI, especially in its early stages, it may follow several courses of, as we know. The inability to forecast the progression has hampered the development of other therapeutics. Also, the response to boluses of furosemide might help to anticipate the course of AKI episode. The diuretic response, as we know, it's a surrogate or the diuresis is a surrogate for renal tubular integrity. So if there is urine is coming out after the diuresis, this is an surrogate or an indicative of renal tubular integrity. So the validation of a test to assess the renal tubular integrity is called Frisomite stress test, or FST. There was a study in 2013, the Cairo et al. They included 77 patients with stage 1 to 2 AKI with evidence of ATN. So those patients, they have ATN. They gave a furosemide of 1 milligram per kg, increase it to 1.5 milligram if the patient had prior exposure. So the classified patient, either he is de novo or he has previously exposed to diuretics, with 1-to-1 replacement of normal saline over 6 hours. The outcome was the progression to stage 3 of AKI. How they will define it: triple or 3 times increase of serum creatinine from baseline, drop of the urine output by less than 3.3 ml per kg per hour for 24 hours, or he received a renal replacement therapy. So this was the Frisomite stress test concept. So the patient with AKI, based on the ACAN definition, stage 1 or stage 2. So if the patient is a native furosemide, what does it mean? Is a furosemide native, they did not receive a loop diuretics from day 1 to day 7. And within 7 days before the AKI, he did not receive any diuretics. So we call it native subject, or furosemide native. So we will give him 1 milligram per kg. But if the patient was pre-treated with furosemide within the previous preceding 7 days, we will give him a dose of 1.5 milligram per kg. Then we will look for the response 2 hours after this challenge or after this stress test. What's the outcome is the urine volume equal or more than 200 ml. If yes, so this is a loop diuretic responsive. If no, this is loop diuretic non-responsive. This is, we call it furosemide stress test. So the total volume of 200 or more indicates the loop diuretic responsiveness based on the category, either is a furosemide native or pre-treated with loop diuretics. What's the sensitivity and the specificity of this furosemide stress test to assess the AKI progression? It was about 78%, both the sensitivity and the specificity. The cutoff of the urine output is equal or more than 200 ml for 2 hours. If you compare the furosemide stress test versus other biomarkers for AKI, this was an also area of research which is sensitive, which can be taken in consideration. We have a lot of biomarkers to detect the progression of AKI, either urinary, either plasma, like the urinary indel, or the urine, or the plasma, or the FENA. So we have many biomarkers. Compared the use of these biomarkers to the FST. So in early AKI, the urine output after the furosemide stress test can predict the development of stage 3 AKI. There was several biomarkers were measured in patients with AKI who received furosemide stress test. They evaluated the ability of furosemide stress test urine output and those biomarkers to predict what? To predict the development of AKI stage 3. The 2 hours urine output after the furosemide stress test was significantly better than the urinary biomarkers to predict the progression to stage 3. And they found that using the furosemide stress test in patients with increased biomarker levels, it improves the risk stratification. So they are not using only the biomarkers, they are not using only the Frisomite stress test, but the Frisomite stress test, when used with high biomarker, this is improve the risk of stratification of AKI progression. Okay, now just for moving, because of the time, just to move to diuretic resistance. So the prevalence of diuretic resistance in critical ill patients is encountered in 20 to 30% among the heart failure patients, mainly, despite its frequency, but the term of diuretic resistance remain inadequately defined. But generally, the diuretic resistance is defined as a failure to decrease the extracellular fluid volume despite the liberal use of diuretics, but qualitatively, the diuretic resistance is unsatisfactory rate of diuresis despite the adequate use of diuretic regimen. In clinical settings, this is the general definition, but in clinical settings, the diuretic resistance has been expressed as a fraction of excretion of sodium of less than 0.2%. So if I have FeNA of less than 0.2% with diuretics, so we call it diuretic resistance. And why we use FeNA? Because this is the percentage of sodium filtered by the kidney, which is excreted in the urine. While since long time, Epstein et al., he defined diuretic resistance as failure to excrete 90 millimole of sodium within 70 hours of what dose? 100 to 160 of Frisomite twice daily, between 200 to 300. The dose of Frisomite, if you do not reach a sodium in urine, 90 millimole, so within 70 hours of those doses, so we call it diuretic resistance. These are the mechanisms of diuretic resistance, many mechanisms. How to overcome the diuretic resistance? We have either to use a continuous infusion of IV diuretics, Frisomite, bumetanide, or trisimide. We have loading doses, then the continuous or the dose of continuous infusion rate, it will depend on the creatinine clearance, less than 25, 25 to 75, or more than 75. Based on the creatinine clearance, we will go with the, for example, here, if I will give loading of Frisomite 40, then if I will look for the GFR or the creatinine clearance. If the creatinine clearance is more than 75, I will go with 10, between 25 to 75, 10 to 20. If less than 25, then I can give 10 up to 40. This is the continuous infusion of diuretics. If there is a role of combination of diuretic therapy to address this, yes, to have an effective or maximal safe dose of low diuretics, you can add the metalazone, hydrochlorothiazide. You can use the acetazolamide or potassium retaining diuretic, which is effective. And of course, the acetazolamide and spironolactone or potassium retaining are weak diuretics. So if we are talking about combinations, we are talking about metalazone or hydrochlorothiazides. What about the common methods of using IV Frisomite? So is the Frisomite cause AKI? No, it does not. Frisomite is particularly used for inpatient with volume overload. Few studies have identified the diuretic use as a risk factor, as I mentioned, for AKI. Most reports did not distinguish between different etiologies of AKI. The inappropriate use of diuretics in the setting of hypovolemia, of course, this will contribute significantly to the development of AKI. When you use appropriately in patient with volume overload, Frisomite may resolve the AKI. What's the mechanism? Of course, resolution of intrarenal congestion plus reduction of the renal oxygen consumption. Second myth about Frisomite and the fluids together can prevent AKI in high-risk patients. Probably not. There is a common belief that the co-administration of Frisomite and fluid increase the diuresis without causing hypovolemia. As I told you, the automated match dehydration system using the diuretics and fluids together, it it has a role for prevention of CIN. While some authors, they found a reduction in the incidence of a contrast-associated AKI in patients who did not demonstrate beneficial effect on the progression of AKI. Fluids should be considered as a therapy for patients with hypovolemia, and diuretics should be reserved for patients with volume overload. This is very important. Third myth, is the furosemide is contraindicated in AKI? No, it is not. Furosemide is indicated in patients with volume overload and hyperkalemia, including those patients with AKI. Higher doses of furosemide may be needed, especially in severe AKI, where the risk of, as I mentioned, diuretic resistance is higher. Furosemide can be assessed or used as a diagnostic tool in AKI. What test is this? Is the FST or furosemide stress test when assessing the tubular function and the risk of progression. Myth number 4, is the furosemide that can kick the start kidney function? No, this is not the case. Furosemide may lead to significant diuresis in patients with AKI, and this is indication of functioning renal tubular cells rather than direct beneficial effect of furosemide. Repeated doses or higher doses of furosemide in anuric patient may lead to significant side effect, which is the ototoxicity. Myth number 5, furosemide works better in patient when it's given with albumin. It depends. Furosemide is highly protein bound, as we know, and severe hypoalbuminemia is associated with impaired furosemide secretion into renal tubular lumen. So the evidence supporting the combined use of albumin and furosemide still is poor. In patients with liver cirrhosis and ascites, as Dr. Shams mentioned in his presentation, the administration of premixed lobe diuretics with albumin, here they found it did not enhance the natriuretic response. There was a meta-analysis including 10 studies demonstrated better control of fluid balance with co-administration of Lasix of furosemide and albumin in hypoalbuminemic patients. In patients with normal blood protein levels, there is no direct effect of the combined. So we have to be careful when giving albumin with Lasix. Look for the protein level. If the patient will benefit if he has hypoalbuminemia, if no hypoalbuminemia or normal albumin level, there is no direct benefit of this combined infusion. Myth number 6, furosemide infusion is more effective than boluses. No, it is not. Several RCTs and meta-analyses showed that sustained diuresis is easier to achieve with continuous infusion compared to intermittent boluses. This is one benefit. So the achievement or the sustained diuresis, yes, is with continuous infusion, but there is no evidence that the continuous infusion of furosemide has better outcome. There is no effect on mortality. There is no effect on the hospital length of stay. There is no effect on the renal function or the electrolyte disturbances. Myth number 7, furosemide can prevent renal replacement therapy? No, it cannot. Furosemide has a role in inducing diuresis in patients with volume overload, but has no direct effect on the chance of renal recovery. And I showed you in the SPARK study. Myth number 8, furosemide help to wean anuric patient from renal replacement therapy? No, does not. In patient treated with renal replacement therapy, increasing diuresis, yes, is common reason for discontinuing renal replacement therapy. And diuretics are frequently used for this purpose, but there is no evidence supporting that diuretics are effective to improve the creatinine clearance or supporting the renal recovery. Myth number 9, furosemide-induced diuresis after AKI implies full recovery of the renal function. No, it does not. Furosemide administration may lead to increased urine output in patients with AKI. The furosemide-induced diuresis after AKI must not be considered as a sign of full recovery. In those patients who experience a single episode of AKI and recovered excretory function, still they are remain at increased risk of CKD and increased mortality, of course. Myth number 10, furosemide should be stopped if the serum creatinine is increasing, indicating worsening of renal function. No, not necessarily. Many patients with acute heart failure, they have a rise of creatinine, and there was no sign of true worsening of renal function associated with impaired outcome. So a similar effect was, as I told you, was observed in the FACT trial. There was a restrictive fluid therapy versus the liberal, and the requirement for renal replacement therapy was even lower in this group. The last myth, or myth number 11, for Frisomite resistance, should we add metolazone, chlorothiazide, or tolvaptan? Yes, but you have to judge as a clinician. Thiazide diuretics are effective in relieving the resistance to loop diuretics, being the second line. Oral metolazone appears to be equally effective as IV thiazides as add-on to loop diuretics without an increase in the safety concern. Metolazone may have an advantage due to reduced cost and longer half-life if you compare it to the IV thiazide. What about tolvaptan? Tolvaptan is a vasopressin receptor 2 antagonist. Usually we use it to treat hyponatremia resulting from SIAD or heart failure or liver cirrhosis. It results in excretion of large volume of water. Tolvaptan does not seem to be used in routine practice in ICU patients for many reasons. First is uncontrolled water removal, rapid rebound water retention after discontinuation, which is a very common side effect, and the intracellular dehydration. Moving to last two slides. What about the practical usage of diuretics in AKI? Usually we need higher doses, especially in patients with prior Frisomite exposure who are not native or naive, because the GFR declines. Frisomite 200 milligram is the ceiling dose when you are asking about the maximum dose when you before judging about the diuretic resistance. There is no clear evidence that the infusion is superior to intermittent doses, considering the concomitant use of diuretic that inhibit the sodium absorption in the distal convoluted tubule, like metolazone or hydrochlorothiazide. And this is the approach, the practical approach when to manage how to manage the diuretic resistance. First step is to maximize the loop diuretics to the 200 milligram. Then if you reach it and the urine output is still not adequate, so you will administer the boluses plus continuous. Then you adopt those if you have if you fail this approach, so you had the combination of infusion plus metolazone. This is the clinical effect of Frisomite therapy if you have harm or no significant difference on benefit. So there is a significant benefit in patients with high risk for volume overload. If you administer with albumin in hypoalbuminemia and diuretic resistance in patient with AKI with volume overload. This is the proved benefits with for the oral diuretics. There is no significant difference to wean off RRT, or there is no significant difference when to use continuous versus intermittent. This is like a summary for the use of diuretics. Final words: the IV diuretics are a useful tool in the management of AKI-associated volume overload, unlikely to be inherently toxic when used appropriately, but unlikely to have a therapeutic role in AKI as a standalone therapy. There is a vital area of uncertainty in AKI. Does protocolized strategy of intensive volume control, what I mean is diuretics plus minus renal replacement therapy, improve outcome or not? Thank you. I apologize for exceeding my time. Thank you, Dr. Sharbat.
Thank you, Prof. Thank you very much for the brilliant presentation. It's very informative and very professional as usual. And I'm sorry, guys, we have here a couple of questions, I know, but because we are running short of time, so I have to move to the next lecture.